good evening, everyone. Welcome to tonight's session. A bit of introduction from my side. If you're a familiar face here, you know me by now. I'm Dr. Queen Ramarasi, and welcome to tonight's session. Mina, today I'm very excited. I'm so happy to have a former classmate of mine on board, but not only that, but to also learn about clinical virology. Because myself, like many other, we do not actually have a clue in terms of what is clinical virology and how do you actually become one? And I think Dr. Maseko, you don't mind me calling Moepeng Maseko.
Yes.
Wink, wink.
Please.
you, you want to teach us, but for the audience, we have Dr. Moepeng Maseko. She is a clinical virologist, and I know when I say clinical virology, some of us are like, what is that? But we'll find out more. There's more that we need to learn. There's more that we need to know because me personally, when I think about viruses, I'm like, okay, there's HIV, there's herpes, and there's only so many. Does that translate to the fact that when you go learn, you only learn like, a small niche, but I'm sure there's more. And the work in race time, I'm sure there's more. It's just that we as clinicians don't know much about viruses except for HIV, which is the one that we commonly deal with, amongst others. So I'm not going to waste any further of your time. I will ask you a couple of questions, which I hope will answer majority of what we want to know. But nonetheless, at the end, please feel welcome. This is not a formal sitting by any means. To ask you questions, interrupt us, raise your hand, and then if you want to wait till the end of the talk, then it's absolutely fine with me. Moepeng, welcome and introduce yourself to everyone that is meeting you for the first time.
Thank you. Thank you so much. As Queen has already said, my name is Moepeng. I am a clinical virologist, which is interchangeable with medical virologist. It just depends what people call themselves. And basically a pathologist specializing in virology. Now, I mean, it is very difficult to be in a field where everyone is like, oh, what's that? Simply put, virology is the discipline that deals with diagnosis and management of viral infections. Now, you think there's few viruses, but there are actually so many. Like in the lab, okay, number one and the star of the show is HIV. But there's so many others. When it's winter time, we have a respiratory viral panel. It has many viruses that can cause all sorts of different things and then all sorts of complications. Daily, as a clinician, you have a meningitis panel. There's many viruses that can cause all sorts of meningitis-like symptoms and complications thereof. And then you have that I haven't even touched the herpes viruses. I haven't touched the transplant viruses. I haven't touched the exotic zoonotic viruses. So things you get from animals, things you get from travel, all sorts of things. So it's a big study and it has different implications. So if we're studying it, it depends on your population. If you're saying clinical medical virology, you say how old is the patient and you take it from there because kids and adults can be affected differently, and that is what the speciality is. We provide the intersection between clinicians and the lab, and we are in that space that's supposed to operate both sides so that the results we get or the test you want gets to the patient and the patient is managed correctly in terms of viruses and viral infections.
That's actually very interesting. And I think I'm judging myself. And I hope more doctors are judging themselves because honestly speaking, if you're in the medical specialties where you send off tests, most of us don't even know what can clinical virology, like testing, like the range of what you guys can offer, in terms of clinical and patient management. But we'll get to that. First of all, let's just talk about what is actually clinical virology. But just as an icebreaker, how did you find yourself in clinical virology? What was the journey like?
Ooh,
How did you actually
okay.
find out about clinical virology?
Um, so how did I find out about it? I mean, I knew it from med school. I didn't know details, but I knew virology. We did the pathology modules. We did virology micro, a path. I knew I hated a path from the moment I got into med school. It was not for me, a path. I just didn't like it. But after leaving med school, internship, community service. I worked during community service, I was in Friedenberg, and during Friedenberg, we had to rotate at all the different clinics. So when you were at the different clinics, if you weren't based at the hospital, then you would see the patients. Then the sisters would be like, oh, sometimes we're keeping files aside for the virologist. The difficult cases we keep aside for the virologist, then they will come and see those complicated patients. I was like, virologist, what qualification do they have? And then they were like, oh, I don't know, we don't know. So I never actually got to meet the virologist, but I just thought that was fascinating. I did my own research because those cases really were difficult. It was like I mean, I don't remember. It was like failing treatment. I don't know. It was HIV, multiple infections with other things, opportunistic infections. It was difficult, difficult cases. And that was the first time I think I was ever exposed to the word virologist outside of med school and the people that lectured us, because sometimes we think that's all they do. They come lecture us, but that's it. After ComServe, I worked at another community day center in Somerset West, in a township in Somerset West. And there I used to see more patients, complicated cases, and we'd have to refer them. They also used to have, there was a clinic, I can't remember where it was, where difficult HIV patients were referred to this one specific person, virologist. I was like, this virology thing. So some more research then. But the whole time that I was in service after med school, I saw how HIV affects young Black women. That was my whole thing about being in medicine, wanting to be in a field which somehow changed that into positive or service delivery for people that look like me and people that were like me. And that was young Black women disproportionately affected by HIV, disproportionately not on treatment, highest rate of infections in certain age groups between 15 and 49 or 35. So that's what I wanted to do. And as virology kept coming up in terms of difficult cases, I thought, okay, virology, HIV, that's me. When you get into it and when you do more research, you see it's a bigger scope. So I also wanted to do public health because I thought that would be the biggest way to make a difference in terms of all these HIV infections, in terms of policy, in terms of on a bigger scale. Instead of one patient at a time, it'll be more patients at a time. And I chose well because virology is basically some infectious diseases, lots of public health. So yeah.
Yeah. And then how did you apply? So you were, you know what, you're giving a lot of doctors hope, I feel, because you know, post community service, all of us want to be in a tertiary setup, but unfortunately, like only 10% of us out of the 100% of the post com serves find themselves in a tertiary institution where you're like in a proper department. Most of
Mm.
us we start off in the peripheries, like in the smaller hospital, the district hospital, OPD, you know, that type of vibe. So the fact that you were able to pivot from that kind of setup into virology and then back into academics, I think it's something that, you know what, it's giving hope for some people because I've worked in district, I've worked in smaller hospital. When you sit there and you're just like, guys, is this what my career is going to end up being for the rest of my life? But let's talk about the transition between um, that time in Somerset West into you actually applying now for Ridge time. When did you decide that, you know what, I'm going to apply for virology, and then how did you actually pivot into Ridge time then?
Uh, I loved my time in Somerset West. I would have stayed there forever, actually. I don't know, like what happened to actually move on, but I had been thinking about it in terms of virology, and I had a friend who worked at the NHLS. And then I spoke to that friend and I asked, there was micro, there was heme, so they told me all about the different specialities. They were like, read up on it, see what they do, which I did. And then they were like, you should come visit the lab and see what people do. So I think I never got a chance to visit the lab because I didn't spend much time in Somerset West. I think I spent 4 months at the clinic there. Then it was COVID. I had moved, it was COVID time. So I didn't get a chance to go to the lab because they were dealing with the COVID thing. But a friend of mine worked at the NHLS, and when the advert came out, they sent me the advert. And literally, that's how it was because I had made inquiries to be, how do I come to the lab? I want to see what you do in the lab. I want to speak to someone in the lab. So I spoke to someone over the phone. I never got a chance to go to the lab because I couldn't. It was COVID. But that's how I got there. That's literally it. Speaking to people. And it's also classmates. You know, you meet a classmate and your classmate is doing this. And Facebook is still a very important tool because when you go on Facebook and you read, people give you all sorts of things. There was a classmate of ours who did their ComServe in the lab and he got a whole bunch of people to write summaries about what they actually did. So he was in an EdPath, he wrote what he did in an EdPath day to day, what to expect, what your future is. And then there were other summaries of people would comment under that comment to say, I'm doing micro and this is what we do. I'm doing viral and this is what we do. So for me, lucky for me, he had done viral in ComServe. He rotated 6 months in viral, 6 months in an EdPath. He didn't like viral very much, but he loved an EdPath, but he told me everything. So social media is a big thing if you want to meet people, meet contacts, and reach out to everyone. Just message everyone and say, hey, what are you doing and how do I meet someone in there? Every time I've had many people message me on LinkedIn to be like, I see you're in the lab. How do I come visit? And then I'll send, you give out emails of your HODs to say, please contact them. And then you tell them, I gave your number to this person or I gave your email to this person. They're going to email. They're like, oh my gosh, yes, let them come. All the time.
Mm.
There's no, oh, don't, there's no nothing. Any information, just reach out to people. You'll be surprised how much they give you. I write pages and pages when people ask, what is virology? What do you do every day? It's on my LinkedIn. So, yeah.
Yes. So we'll definitely make our way to your LinkedIn profile for those that just want to learn a little bit more. And you interviewed without, because we've spoken to pathologists before, and what they always say, I must say, honestly, in my next lifetime, I'm gonna come back as a pathologist because pathologists for me so far have been one of the most friendliest, welcoming, I think doctors that I've had a privilege of speaking to. Like you can gauge that, what, this is more of a, supportive working environment, which is what you get. You don't typically get that in the hospital. So most of them would always say, come to the lab, come to the lab. But it's
Yes.
so interesting that you didn't go to the lab, you applied. So basically it just speaks to alignment, you were just meant to be a clinical virologist. And I'm glad that you are sharing in terms of how do you actually become a virologist. So training time. Now you applied, the interview. How was it? You applied and then
Yeah,
shortlisted.
you know,
What did you put in your interview? Like in your, not your interview, your CV that what made you
eh,
stand out for those that also want to follow in the same path as you?
I don't even know. I finished my ComServe 2020 and then I was unemployed for 1 month. Then I got a job in private Friedenberg Life West Coast Hospital. I spent 3 months there, but I was looking for a government job. I always knew I wanted to be in government, never ever private. So I spent 3 months at that hospital. Then I got my Somerset West job there. And um, that was my whole experience. That was it. That's what I put in my CV that I worked in, but I put because you had to write when you apply, you send your CV, then you must write a motivation, and then you had to get two references to email uh, references directly themselves. They email the NHLS. You write your motivation, they write their motivation for you and email directly. My CV was very short. All the courses I had done, obviously the BLS and all of that. I didn't have an HIV diploma. It was in my plans, but I hadn't done it yet because I just finished ComServe now, and I was going there. But the motivation is the same. I had told them that I had worked in a community. Friedenberg, West Coast is like a rural town because it's far from the metro. It's like the West Coast district. The clinics there, patients struggle. You know, they have a set number of people they can take for the day. They see a doctor once a month in the clinic. So it's not like they save, the nurses will gauge which patients deserve to see a doctor and all the difficult cases are put aside. So that's what I put there. I'm like, if you have a difficult medical condition, if you have a serious medical condition, you are expected to wait a month before a doctor comes there. How is that fair? How is this our health system? And that's what I wanted to do. Applying for this would help me equip myself and hopefully go back to these places that where you need these specialities. They shouldn't just be concentrated in academic centers in the cities and everywhere else. You can spread them. That's what I put there. And I said virology was introduced to me in ComServe, difficult cases. I never met the virologist. I hoped I would. The day she was supposed to come, she didn't. But it's always been like, I would like to be that person for those people, people that look like me, females, young,
Mm.
whole lives ahead of them. They want hope. I want to be that hope for them as a clinician who provides healthcare and is good at what they do. That's what I said. The
Wow.
interview was, it was in person in COVID. I was like, oh, it must be online. They were like, nah, come. And I got there. It was three people in the room, HR, two of the professors there, and there was one online. And they were like, hey, how are you? I was like, oh my gosh, hi, I'm sweating. They're like, no, it'll be okay. Then they were like, why do you want to do virology? Meanwhile, all I'd read was online. So I said the same thing. I said, HIV, I want to know more. I want to do more. I want to be. They were like, oh, okay, you seem like you know about HIV. So they're like, I'm sure you've thought about this already because they were like, if you could do research related to HIV, what type of research would you do? What type of topic would you do? Tell us about that and tell us why you would do that. So, I mean, the lesson there was if you're going to say something in an interview, you must be able to back it up. You must have done research about it. You must have read about it. You must have all of it. So, I don't, they have said questions, but those questions are dependent on what you say. If they were like, you want to be a virologist, I was like, I love HIV. I love it as a virus. I love it. I would like to know more about it so that we can see how we make lives better. It is our crippling factor in our health system. They were like, okay, you love it so much. You must have read about it. Tell us more about it. So that interview was like, tell us about HIV. Tell us about HIV. What have you read? So they wanted to gauge whether I was being serious or not. So that's the tip for interviews. If you're gonna say it, that means you've read about it, you know about it, you can answer about it. Notice how it's not about what a virologist does, what it's about your interests because you said you're interested. Yeah. So basically, that was the interview. That's what they asked. Things I said. Then they would be like, oh, tell us more about that, what you said. Then they asked normal things like, what do you think a virologist does? Now they were just trying to gauge, have you been to the lab? Have you asked around? But they also want to know, do you know a little bit of what you should be expected to do? Because some people come there looking for adventure. It's going to be so much fun. It's going to be exciting. And then you get there, it's just a whole lot of reading, a lot of learning, rotating in the lab. You don't interact with patients too much. So are you going to be able to handle that? Are you, and those are things you would have spoken to people about to say, oh, we see patients this amount of time. We don't see patients this time. We spend this amount of time in the lab and so forth. So that was what was asked in the interview. You don't have to know what they exactly do in the lab, but you must have interest in what you're saying you're interested in. So that means you researched around it.
Wow.
Yeah.
That's so interesting. That's actually very interesting, I must say. And then, okay, you got in and the training time. So obviously, okay, stepwise, for people that might not know, clinical virologist, you are a doctor. And what that means is that you need to get your MBCHP 6 years, do your internship, do community service, and then apply to specialize in clinical
Yeah.
virology. So the training time, you have a master's dissertation slash research that you're doing, but also you have exams. When do you write your exams? Like, what's the training pathway like once you become a rich in that 4 to 5 years? And
Yeah.
when do you write your exams?
So when I applied, it was during COVID, which obviously tried to take over from HIV a little bit, becoming this special child. So not many people knew about virology at the time, but now they know about virology after COVID. There wasn't a prerequisite of you should have this, you should have this. But for now, if you want to apply to virology, you should have a diploma in HIV. So I did my diploma. When I got in my post, I had to do my diploma within the first 6 months I was there. So I got in and then I was registering to write the diploma in the next 6 months. And that's what I did. Wrote it, passed it, done. So that 4 years, they have set timing for you. where, because it's not like other specialities, you can't write primaries before you get in there because you must be in the lab to sort of get the experience and know how to prepare for your primaries. They give you, I had to write within the first 18 months. So at 18 months, every registrar must have their part ones. So that's how your training is set out to prepare you for part ones in the first 18 months. So you can write, now they've changed it, they're not as strict as by 18 months. I wrote my primaries at 18 months, but now they said you must have done more than a year, but by 18 months you must have it. So you can write after 12 months if you feel like you're ready, but everyone will write closer to the 18 months so that you get your part ones. You can calculate for yourself because you must give yourself enough time to write again if you fail, so that by 18 months you have them. Because that's all they say. By 18 months you must have them, but you must do a minimum of 1 year. And then after that, so it depends on your department. In virology, they were like, you just arrived here, let's acclimatize you. We have different rotations in the lab, different sections where they do different things. So they didn't rush me into an M-Med, but they said you are expected to have your M-Med before ideally you write your final exams. In terms of topics, you could come with a topic if you already had what you wanted. You could come and say, I want to do this, and then you could develop that. Or they could provide you with a topic, and then you can develop that and say which direction you take it. I was given a topic and I went in a direction I wanted. That was after my primaries, I was just focusing on my M-Med and then preparing for finals and getting acclimatized to like the next step of being a registrar. It is 4 years with the option to extend depending on where you are in the journey in terms of exams, in terms of your M-Med, and so forth. But strictly speaking, it's a 4 year degree with an M-Med at your registered university of choice. They don't have strict guidelines of you must register for your M-Med in the second year, third year, or fourth year. You are going according to the timeline of what is happening dynamically for you. But by 4 years, you must have your part twos and your M-Med. That is the aim.
Mm.
Yeah.
And then the studying part, because you're preparing for your part ones, you also have a part two coming. Guys, 4 years, you think it's a long time. 4 years is it's like 2 months, feels like 2 months, at least if you have something that you need to do. Now you have this demanding research that you need to allocate time to do. Like for you, practically speaking, because I mean, being a registrar, I think no matter which department you are, it's hard. What would
Yeah.
be your advice to actually, finish this thing on time, get your MA done, and write your exams on time? Studying tips that you would give for doctors or potential or even registrars currently navigating that path?
I think you must know your strengths. You must know what works for you and what doesn't work for you. And you must figure it out quickly when you arrive. You can take time to acclimatize, to learn, but from the beginning, you must be focused and you must learn what works for you. I am a morning person. In the morning, I am the best person on earth. Nighttime, this is my energy level. I should be in bed by 8 o'clock every night. That is what I want. That's my dream world. So, for the first 2 years of my Reg program, every single day I arrived at work between 5 and 5:30, latest 6 in the morning, and I'd sit in the office. Sometimes 6:30, it just depends how much energy, but no later than 6:15, 6:30. That's already too late. But I would study in the morning. Everyone got to the office around 7, 7:30. Then I would stop. Then the day can continue. 4:30, everyone left for the day. I stayed until 8. That was Monday to Thursday. Every single Monday to Thursday in the morning, I studied, and in the afternoons. Friday, Saturday, Sunday, you would not see me touch a book. I was determined to have a life. I didn't study. I didn't. I was seeing my friends, I was outside. If I was going to church, I was going to church. If I was traveling, if I was doing it. I did that for 2 years. Closer to exams, you can change it up because you have to do more now. You can't be outside. You have to be there on Fridays, Saturdays, and Sundays. But that's what I did. I work very well in the morning and at work. Don't ask me to work at my house. I cannot do it. It's my happy place. It's my happy place. I can't do it. So that's what worked for me. Everyone must just figure out what works for you. And it's a pacing yourself so that in the end you're not rushing. That's what I did. So you must figure out quickly. And you can try different things, try study groups. It's a very lonely speciality because when I wrote my exams, I wrote in Cape Town alone. I think there were three of us in the country writing. So it's hard to have a study group. It's hard to study with other people if you have fellow registrars, but you're at different points in time as well. When you are wanting to study there at work, when you are wanting there outside. So you have to be disciplined actually by yourself. It is possible, it's done. So you must just know yourself. Number two is you must take every opportunity. When they say, oh, there's a presentation on this, listening to other people helps because you get to see other sources wouldn't have gotten to. The problem is that information comes out, information changes. Today we have this, today we have that, or have you heard this? Have you read this? And it helps. So if you're listening to, if there's talks, if there's echoes, there's so many academic opportunities during this journey. Go to the echoes, go to Journal Club, present. If they say, do you want to, you say yes. You'll figure it out later. Just say yes. And that's opportunity to study, opportunity to do something you wouldn't normally have done. Just say yes. Just yes, do it. And then ask for help. Ask for help along the way. Stalk your consultants, stalk your colleagues that are your seniors, stalk them and say, hey, please help with this, please help with this, please help with this, please help with this, the whole time. And the last thing is you will make mistakes and you will survive. I've made so many mistakes in the lab. And then you go and tell your consultant and say, hey, I messed up. They'll be like, okay, it's fine. We'll fix it. It's fine. Now we
Mm.
know. We can just call the doctor. Just call the doctor and say, hey, we made a mistake and this and that. And you learn from that. And you
Mm.
never forget it. The thing is, when you call and you rectify and you explain, and doctors are also so nice. When you tell them, hey, we did this and this, we actually wanted to, they're like, oh, okay, thank you so much. To them, it's not even that big a deal. You were like, oh, my life is over. My life, it's never over. So you will learn from your mistakes because you'll make so many of them. It's a part of the learning. You will be a better virologist or pathologist or whatever for it. That's it.
Yeah, no, you are putting a smile on my face, Moepeng. The things that you say, I like the fact that you said balance and you took care of yourself while in the program because, yeah, I think you cannot be studying and studying and studying and somewhere, somehow you need to strike that balance, but also give yourself grace to be able to learn. Because if there's one thing that I've heard in the past from one of the speakers was that when you go into rich time, literally you're a learner. You're starting from scratch. So the
Yes.
learning comes with, falling. You need to stand up, pick yourself up, and accept yourself as a learner. You're learning in that four
Yep.
years. So this idea of us wanting to come in there, being perfection, like perfectionism, knowing alles, it's not it's not healthy for us. And I'm so glad you did mention that it's quite something that I hope will accustom our minds to actually think and view it that way. So and then when it comes to so you are working for the NHLS and you're paid for the NHLS and when you're a reg your salary is capped and now you have school fees you need to pay for the university fees for the MEd and you need to you can't locum you can't some people don't even want to entertain the idea of going into reg because your earning potential sort of does this you know
Mhm.
so how was it like in general in terms of what can I say your earning potential in the program itself, but is it the thing that you think okay there's a ended site once you finish you will recoup whatever you lost there?
Well, for me, I went into it early. I was still a grade one MO. So when I went into registrarship, it was the scales are sort of aligned. You make a bit more in government because NHLS is parastatal. It's not quite government, but it is government. It's aligned to the government. So the doctors there and the doctors in state, it's a bit different, but it's not that big of a pay cut. The scales are sort of similar. So it's not like I came in as a grade two MO who had to lose their salary, number one, but we still have overtime. So you don't, there's not much in terms of what you get paid. You are right about the university fees because you must pay university fees. You do get a discount. They say, the university says you get a discount, but it's still a lot of money. For each year that you're registered, you are a registrar, you pay the university. The year you register your MMed, you pay more. So every year, like I was year 1 to 4, I think I paid UCT. How much did I pay UCT? Like at the end, it was 18,000 Rand for the year. That's for the year. Each year, like 1, 2, 3, 4. Every time at the beginning of the year, we register just like regular students and so forth. When I wanted to register for my MMed, as in this year, I knew I was going to submit my thesis. Then I had to register an MMed extra. So I was registering as a registrar doing the specialization. Then when I was doing my thesis, I had to register for the dissertation. So I was MMed 1, MMed 2, MMed 3, MMed 4. That's just, I'm a registrar. When I was submitting my thesis, then I had to register dissertation, and then that's more money. That's an extra amount as well, on top of your registration fee. So that was a bit much, but you submit your thesis, it gets marked, and so they had to pay those people that mark and all the administration related to that and graduation and when it's marked and you pass. So that was in terms of finances, but I don't think if you were grade 2 or grade 3 coming to a rich post, then you would take a dip. Other than that, I mean, your salary stays the same, your contract employee it stays the same in that sense. That's not ideal, but it's only for a limited period.
Mm.
So, yeah. But it's being a student. I mean, finances, yes, but that student life is so tough. Working and studying yeah, it's a discipline thing. It's a discipline thing. That's why I say you must know your strengths and you must do what is your strongest strengths and do it well. From the beginning, from day one, you literally have to be like this, saying it's just 4 years like this. But
Mm.
looking after, otherwise, you'll go like this. And then the next thing you know, you are out of time and you're still not okay. So I made the decision and I was like, not Friday, Saturday, and Sunday. It was such a big thing for me. My friends would always be like, do you sleep? You're always at work. But I would see them every weekend. During the week, just don't bother me. I would see them. So yeah.
Yeah.
I don't think it's
Okay.
a huge financial, but I guess I don't have many responsibilities. So I'm sure for people it was challenging in terms of
Mm.
fees and all of that. Yeah.
Yeah. It's definitely something to actually think about and to be aware of because some people don't actually know that you need
Yeah.
to pay fees like a normal student. And there's a question on the floor, and I think it boils down to you need to tell us like what does your work entail? So they're asking, good evening. I have a question. I assume lab staff also rely on analysis from the machines, if I'm not mistaken. In that case, are we not scared that in the future AI might take our work? So what do you guys do actually? And also, are you
Uh,
guys scared of AI, the big AI that's gonna take away all our jobs?
No.
Yeah.
So day to day, you would be like in the virology, I'll describe how my training. So we had different sections in the lab that were virology, and you have different types of tests. So you have serology tests. Those tests are looking at antibodies, antigens. So those are your IgMs, IgGs. HIV tests is a serology test, for instance. So you have that bench. That bench has responsibilities, and you have a certain number of tests that are done there. So we'd rotate there, we'd manage all the tests there, you'd manage like quality control, quality assurance, all of the things related to how are we guaranteeing that these results are correct, they're accurate, and they're communicated correctly to the clinicians. Then we had a section that's called automated molecular, which deals with everything that's automated, where you take a sample and you load it on a machine, and then you get out a result. So that would be things like early infant diagnosis, HIV PCRs, HIV viral loads, all sorts of viral loads were automated molecular. Then we had a section that was manual molecular, which included a bit more manual work where you had laboratory scientists that had to do a bit more. in terms of the work was a bit more manual, and then it involved a bit more steps, and it's either different types of panels like our respiratory panel, meningitis panels, and all of that. So all of those sections have different people, they have different things you have to check, they have different quality control measures and all of that. You get a result from the machine or from the technologist, or you get a worksheet, and your job so we rotate through those benches, so we learn how the machine works, what is the process, and what is quality control steps, what does contamination look like, how do you troubleshoot this, how do you do that, so that when you are getting a worksheet and getting a result, it's not just, oh, this is positive, oh, this is negative. No, you look at the patient's clinical picture. That's why we would stress clinicians, please write a history on your request form so that if we get a result, we can see if it correlates with what we're seeing online. So you would get a result sheet or a worksheet with results. You'd go on track, and then you see the patient history. You'd look at previous results, what other tests had been done, and if this result makes sense. So sometimes, and why we are not really scared that AI would take over virology like that is that the manufacturer will design this assay that we use to test for, let's say, Hep B surface antigen. Okay, we can use that. No, Hep B surface antibody. The manufacturer will say, if it's less than 1, it's negative. If it's more than 1, it's positive. But through clinical trials, research, and all of that, we know that if you have more than 1 but less than 10, you are not immune to hepatitis B. So when you get a vaccine, we know that we look for a certain level of titer that research has proven that it's protective. So that is an interpretation thing, that is a clinical thing, that is not a machine. So we do that with all the tests. If clinically, or if a test is here and we see, oh, it's positive, or it says the number is this, but it should be positive, and we see your whole history of results and it doesn't correlate, it doesn't have to be interpreted as positive. We can put there negative and write a story and say, the machine or the test result was this, but due to the clinical, what we saw here and what other tests, we think that it's not clinically significant, or it's clinically significant, or the test was negative, but we think that you should still do this test to prove that this is actually what's happening. So a machine can't really put 2 and 2 together, and that's why we're not really scared. We love AI. We are trying to incorporate it somehow into making life a bit easier in terms of tracking trends, tracking what is happening, outbreaks, and all sorts of things. So we want to incorporate it more, actually. And I think that's one other thing. So day to day would be results, authorizing, looking at clinical pictures, correlating with results. That's number one. But it also involves ward rounds. You would go and interact with clinicians where they would, we'd have ID rounds at the pediatric hospital and ID rounds at the adult hospital, talking about, do we think this is viral? Do we think this is bacterial? Stop antibiotics, start antibiotics. Or you think just because there's no antivirals, common antivirals, or many antivirals that are used, virology is not important. But it's important in terms of not overusing antibiotics, or not underusing, or not unnecessarily putting people on treatment that is actually not going to help them because this causes a virus or stuff like that. So we are involved in that. And then surveillance is a big part of virology also. We have the National Priority Program at the National Institute of Communicable Diseases, where they track all our HIV viral loads, where they monitor like suppression rates of communities that are doing viral loads. We have our national antiretroviral programs, and we monitor all those people and how they take their medication. Is it good? Is it bad? You can track it down to a region of, oh, this area in Cape Town, people are not taking their medication. We have high rates of no suppression of viral loads. That's worrying. Let's talk to the clinic sisters. Let's advise to have education. Is there a supply issue? Stuff like that. So it's a big field, actually.
Yeah, no, thank you so much for that. I think if there's one thing, I'm glad that we're not scared of AI, because I think as much as AI is like automated, they still needs a human. They need a human to actually interpret and make sure
Yes,
that it's
true.
accurate in what it's saying, because it has clinical implications for the treatment of patients. So I think in medicine, I would say we're still fairly safe for now.
I think
Until
so.
further notice, obviously. We'll see if AI advances to a point where it takes over our IQs, then I don't know. And then the other thing that I wanted to ask you, like a day in your life, what does that look like? If you can paint a picture for someone who's like, is virology something that I can do in terms of work-life balance? So you
Yes.
come in the morning and then, yeah,
Virology is
what
the
does your
best.
day look like?
Actually, virology, there's only not just positive things about virology, so but I'll just mention the really positive things about virology. I think it's the best because nothing is super urgent. There's nothing that's like, oh, the patient's going to die now. There are things that are urgent, like transplant medicine is important. You know, when they get organs and they're like, oh, we need to know about this and that. COVID used to be a big thing. It's not anymore, where they would want to know if they want to do a lung transplant, is we must do a COVID test and then have a result and so forth. So that was important. But other than that, everything is not do it now. You can do it later, tomorrow when you get to the office. So if you get to the lab now, there would be overnight work. So you would log into Track and see what's on the queue and what type of work is there. Is that work entered manually by like a laboratory scientist, or is that transmitted from an instrument? And then, depending on what is what, you would sign out all of that morning work. And then, depending on what type of institution you are. If you are in an academic institution, you'd have days where you have ward rounds. We used to rotate through the clinics, the infectious disease clinic, the liver clinic, because hepatitis B, hepatitis C, those are all viruses that people are treated for. So there would be tutorials that you would have to do, and then you also lecture students. So you lecture undergrad and you lecture postgrad. The undergrad would be the medical students, where you have specific days where you're assigned to lecture, and then postgrad would be the like the honor students that you would give some lectures to, or the students, laboratory scientists that are rotating in the lab that you would do lectures and tutorials with while you are there during the course of the day. So that is all set out in a weekly timetable where you know what is what. Then most of our work is put up in the morning. So in the morning, you'll do last night's work. During the course of the day, all of the day's work would come out. And then you are just basically waiting for either to call out really important results that are where you ask that and make sure that patients are on treatment. One of them would be if you find HSV1 on CSF, you would ask, hey, call the doctor and say, is the patient on acyclovir? That's a life or death situation where if the patient's not on treatment, there's a high possibility they could pass away if it's in the CSF or on tissue, brain tissue. Um, and then you just wait for queries. That is the afternoon. And then other there's a echo where we do like the educational presentations. We have national virology echoes where each center in the country takes a turn presenting. So you have all the provinces that have virology have a person that will present every Thursday. So we take turns, and then you have a chairperson for the session, and then they ask different consultants to mark you for your portfolio. So each registrar, we sometimes have guest speakers there, but each registrar gets a turn at least once or twice a year to present whatever. You can present whatever. It can be a lab aspect thing, it can be an interesting case, it can be like a quality assurance type of thing in the lab, but you present to your fellow colleagues, you get a chance to interact, and then someone will give you a mark, and then you'll get emailed your mark after the session, and that goes into your portfolio. Then you also have to participate in infectious disease presentations with the rest of the infectious disease team, including the internal medicine registrars, the infectious disease fellows, the microbiology registrars. We do joint ward rounds. And then you have journal club that you must also present at least once a year, where you'll present to the rest of the scientists at UCT. So UCT had virology diagnostics and virology, the UCT side, where you have scientists that are virologists that work on mainly research related to like vaccine trials, HPV, HIV, all sorts of other things. So it's not just clinical and diagnostic, it can be clinical trials and all of that. So yeah, that would be a full week. So it depends where in the cycle you are in terms of academic. If you are not an academic center and you are just service-based, you would just be doing all of that minus the journal club, I guess, because the presentations stay the same. There's journal clubs in different forms in each center, but you are basically doing all the work and advising clinicians or laboratory staff on troubleshooting, making sure quality assurance, maintaining accreditation, and preparing for internal audits and audits. Yeah.
Hmm. That's
So
actually doable, hey? Very, very
yes, it is.
interesting. Doable,
You would,
like work-life balance. No wonder you guys are so happy. No,
there
it's
is
good.
nothing to cry about,
It's good, man.
except,
Oh my God, it's so
and the
good.
work is
And
fun. It
yeah.
really is because half the time, clinicians, like you said, don't know what virology is. So if you call them, you have great conversations. If they call you, you have great conversations because you tell them something, they're like, oh, okay, I see. Oh,
Mm.
okay, that's nice. Yes. So most of the time, you get request forms and they're like, oh, viral panel. And you get a sample and they're like, viral panel. Then when you call them, you're like, hey, you said viral panel. Which one? We have a bunch. Then you start talking, oh, the patient is a 50-year-old who has like meningitis symptoms. So we were thinking a meningitis viral, but we're like, yes, we have one of those. And then, it's easy. It's great discussions. And if you see any of our comments, they'll be like, if you need further assistance, please call me. And we'll put our cell phone numbers there and say, please call us. Please call us. Because it's better to know which test to do than to waste a lot of money. These tests are so expensive. Molecular tests are not serology, is antibodies, antigens. It's easier, it's shorter time for testing. When you do the higher nucleic acid test, like detection tests, they are expensive. It's almost 1,000 rand for that test. So if you're wasting doing the wrong thing. It's government resources that we already don't have. It's a waste of time because these tests usually come up to 48 hours later. You've wasted the patient's time and you've actually shortened your window period for treatment. So it's important if you call, no one will ever fault you.
Yeah, no. And then opportunities post qualifications. Once you qualify, of course, you can work in private and then you
Mm.
can work in the public sector. You can be in academic or be in more service-based, as you said, like in the periphery. In terms of any potential post qualification. So is it an option of you can choose to go either private? Of course, private is always more, I think, you earn more there compared to government. But in terms of grading up, I'm assuming the earning potential would obviously go with your experience. Am I
That's
right?
where it gets tricky.
Mm.
Virology is not very mainstream. It's firstly, it's not well known, but it's not as nice as a NetPath or Histopath, where they can pick and choose. There's so many posts in private and there's so many posts in government. Virology is a smaller, it's a niche field. There's not that many people, so there's not that many posts and not many people know about it. In South Africa, we have it as a standalone speciality because HIV was such a big thing. And you could actually, HIV comes with a lot of other things, opportunistic infection, transplant medicine, and blah, 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 all of that. But post qualification is where it gets tricky because there's not a lot of opportunity. You have microbiologists do 6 months of a virology rotation during their training. So in private, sometimes private companies will have a microbiologist do virology, cover a bit of their virology section, just so they can have less virologists. So you'll get virologists in private, but not as many as other specialities because sometimes the work is done by a microbiologist. You have clinical pathologists, they do a bit of micro and viro. So sometimes laboratories will have one ClinPath and that ClinPath will do the microviro hematology. So there isn't much opportunity for that. So when you go into virology, you must know what you're going in for. so that you can determine, do you like research? Do you have a specific field you want to go into? Surveillance? Do you want the public health aspect? Do you want the epidemiology? Do you want which way are you trying to go? Because in private, there's not many opportunities. In government, there's not many opportunities. So when you go in there, you must have a plan. Are you going to go and how are you going to go about it? Earning private, I mean, I think public, private, they're sort of equal at the beginning. And then I think in private, you can get a bit more because I think career growth is faster. You know, government, people must retire before you're promoted, posts must come up. That's the same in everywhere in government. But in private, I think you have opportunities to buy into the company after a certain number of years. You get more money, you get bigger bonuses because just people pay for that, while in government, the service is offered to needy people who cannot necessarily afford to pay you. So the government doesn't have that much money to pay its pathologists as much as private would in the long run. But in the beginning, everyone starts the same. So, yeah, if you are thinking of virology, have a plan. Have a plan of where you want to go, where you want to see yourself when you enter the
And
field.
for a roadmap, because okay, you are done with your training. What are the pathways that you can sort of take? You I heard you speak about epidemiology, and then like what
Yes.
pathways exist now post qualification that one can consider.
Pathology is you could be a pathologist, like working in a lab, service lab, where you are a virologist basically doing diagnostics. You can do research, where you could do clinical trials, or you could work in a lab that does all of these, like maybe assay development, sequencing in terms of molecular identification of pathogens. And then public health surveillance, we have a virologist that's in charge of the National Priority Program, where they track the HIV trends, the early infant diagnosis, all of those statistics, and that epidemiology is tracked by them. And you could do outbreak response, where I think there's a virology that's in charge, a virologist is in charge of our outbreak response. Every time there's an outbreak, they do help do the investigation, how it's responded in coordination with other specialities and departments. So, yeah, research, public health, outbreak response, priority programs, pathology, lecturing. You could also lecture. And then, yeah, overseas, there's also a few things like all these, like the Gates Foundation, all these programs that deal with outbreak. You know, West Africa goes through a lot of outbreaks of Ebola. That's a virus. We're now having Bundibugyo. There was Hunter virus. There was all sorts of things. So those are things that a virologist becomes important in when you're thinking about that. So they I don't know if they'll always call it a virologist but they will name all the things, the attributes that you have to apply for that job. But yeah, it's a big scope and you can end up in many places. You just have to know where you want to be.
All right. Yeah, no, that's actually very interesting that you need to map out your path from the start. But I'm sure
Well,
you'll
as
get an
you're
idea
going,
as time goes, you will know exactly where you fit in,
exactly.
what you like. Yeah.
Yeah.
Okay.
And it also
And
depends because you can go further with a specific virus. If you are interested in HIV, there's a lot of people that do HIV research. You can collaborate, you can join them, you can join those teams. They always need, the advantage is that you have, let's say, the research side, and then you have the medical side and the clinical side. So for scientists that just did like their PhDs and their MSCs and all sorts of things, you are an advantage because you have the clinical. And then for the clinical, you are an advantage because you can interpret the scientific part of it. So you are a great go-between and you have a lot of assets to give to people. So if you focus on a specific virus, you can go far with that specific virus, or a certain field, you can go far connecting with the people that are in that field and just making connections. You must just email and say, can I be a part of it? The next thing you're part of a surveillance unit that's doing all sorts of exciting things.
yeah, sounds like more of a FBI work, very interesting, very intriguing. Because I mean, we've had outbreaks and COVID proved one thing, that we need virologists. I don't know how many are you guys in the country. I'm sure it's, as you said, it's a small community. I'm sure we
Mm-hmm.
need more. I'm 100% sure that we actually need more. And then I wouldn't do this talk justice if I don't talk about the PrEP, the HIV PrEP briefly. The I can't pronounce it. Lenacapavir.
Mm.
Lenacapavir. There's been a lot of miscommunication, eh? And for us, in this modern age, we get our information from social media. So it takes one wrong information to land on someone else's status, and then we just reshare, we repost, and then now it's been said that the PrEP is the actual ART, or the ARV medication, which is proven to be a lie. So
Yeah.
now that we have a clinical virologist with us, can you just briefly educate in layman's term? Because this knowledge, I think, it's not only for the general population, but for us as doctors as well, because it's still a new drug. Most of us are not sure um, um, what is it, who can get it, and what is it for. But if you can just give public education to all of us about lenacapavir, please.
Okay, so lenacapavir is the new kid on the block, hot as can be, fresh off the press, and it's a pre-exposure prophylaxis drug. So it's supposed to be used in those who do not have the infection, and it's supposed to be for protection against HIV infection. So before you take it, you're supposed to prove you don't have HIV, as in they will do a test on you and make sure that you do not have HIV. Then you are eligible to take it. So it protects you against HIV infection. It's a twice yearly injection. So it's a subcut infection. So just under the skin, they will inject you once, let's say January, and then again in June, and that's it. So it has its half-life, it lasts for 6 months. And then after 6 months, you go get another injection, it lasts for 6 months. So it is amazing to have to say that we can be protected from HIV with just an injection that lasts 6 months. So obviously, it's exciting. The government has now rolled it out. Last I read, they said there's 360 institutions or centers that have it in the country in different provinces. And they said they brought more doses in the places that need it the most, as in the ones with high prevalence of new HIV infections. So I'm not really sure of a list of where those places are, but if you ask at your clinic, maybe they can direct you to the right place. So we do have it available here. It is there. Just that, with great power comes great responsibility. This injection is not a license to go wild and go free. The same protections that everyone has been using up to this point should be continued to be used to this point. It's just supposed to make it easier not to get infected with HIV. So safe sex practices, not having multiple partners, and getting tested regularly as well, making sure you do not get infected, are things that we should be still abiding by to be safe and be kept safe. Yeah.
Mm. And prior to this, actually, you were saying something very interesting, that with this new drug, now that people know that you can actually be protected from HIV if you are HIV negative by taking the pre-exposure prophylaxis.
Yes.
Now
Now
people are not being responsible,
they
and
are
I
risky
think I think
behavior
you know
has gone
how
up.
you know how much I love my country. I love South Africa because we are such a vibrant, energetic people that with the release of The Polygamist,
Ugh.
the Netflix what do you call this series that came out, and we learned of the character Jonas,
Mm-hmm.
who's like a typical, we think it's just a series, but actually there is it's why we have so much HIV in the country. But understanding that we now have this drug that can protect us doesn't mean that you're protected from getting gonorrhea and all those
Yes.
other sexually transmitted infections.
Yeah.
that can be as equally detrimental, especially to females of
Mhm.
reproductive age. You can lose your fertility if your fallopian tubes get damaged from all that infections that you're going to get. So I think you are the right person. You need to disseminate this information. I mean, we wouldn't be doing justice if we're not advocating and
Yes.
educating the general population in terms of the fact that safe sex practice is still the gold standard,
Yes.
and with your motivation being that you went into virology because of the concern of the surge of HIV, especially amongst young Black female in the country, is something that you hold dear, and you actually specialize all the way to becoming a clinical virologist. But also the fact that we need to be responsible. South
We
Africans, we need
do.
to be
We do.
responsible. Yeah, I think I would leave it to you to give a word of encouragement to the young ones to say that guys, condoms are still golden. It is a pregnancy prevention, contraception, but it also
Yes.
protects you from many, many things.
Knowledge is
Yeah.
power. Knowledge is power. I think there's a lot of knowledge around, but where we get that knowledge is important. Go to official sites, World Health Organization, South African Department of Health, South African government, all sorts of other things. Don't just take an Instagram, a Twitter, and say, yeah, this is my Bible and this is what it says. We must also filter out the sources that we get. But I think the issue is that we've had so much drama in life. There's been so many headlines. I remember it started with there's an increased number of malaria cases in Gauteng. That was a headline for exactly one day. Next day, hantavirus outbreak on a cruise ship. In that same hantavirus, there was that statistic that said that STI infections have gone up. So everyone missed that because since the introduction of this PrEP stuff, there's been more STI infections. More people have presented to local clinics to be treated for STIs. In between all of that, it was hantavirus. So I think people missed it. But the important thing is that decisions we make today affect our lives forever. And that is especially true with viruses. HIV, herpes, all sorts of things. These things do not have implications just for you, they have implications for future generations, they have implications for your children. If you think STIs are a small thing, you as a female, if you get genital herpes, for instance, the chances of you giving it to your child are high if you get infected anytime during birth. The child is now at risk of getting meningitis related to that herpes, skin, all sorts of issues just because you had an STI at that point. So it's beyond us. It's about protecting ourselves, but also our fetus, our children, our family members, where their immune system is not as strong as yours. And if you pass it on to them, the implications are higher and could be life-threatening and cost people their lives. So every action we take should be in context of it's not just me, it's the people around me, it's my loved ones, it's the future I hope to have now dependent on medication and all sorts of things. When the decision was safe sex, using condoms, and behavior that is protective of yourself and others around you. So, yeah.
Mm. Responsible. I think we'll never stop preaching that. We are
Yes,
we
yes,
have we have a what do you call an ethical responsibility as doctors
exactly.
to keep on educating the
Yes,
public in terms of how to take better care of yourself, with everything that's going on. Because even with the HPV, cervical cancer in
mhm,
women. So it's good that we as South Africans we become more responsible and still
yes,
dual protection. Get your
absolutely
injection, but also make sure that you condomize.
correct.
Yeah, and get
And
tested, get
read,
tested, get
read,
tested.
read, read, read a lot. So many of us are
Yeah,
trying to do good things, good educating the public, because when you're aware, when you have knowledge, you can do better. Now this is a advert for myself. I also am a columnist for GQ magazine. Yes, it's a male-orientated magazine, but I think everything communicated there is important for everyone. So just keep reading. There's so many sources out there. There's so many people who want to give information, and hopefully someone will read that information and find something useful. So just read. Read about your health. Read about the benefits of health. Read about everything you don't know about. Read about it.
yeah.
Google, internet, everything. knowledge is at
Yeah.
our fingertips. Just filter your sources.
Yeah, you must have that magazine for us. I hope it's online because we people
There's
don't buy magazines nowadays. We don't buy magazines. But yeah, no, thank you so much for that. And I think to round it up, for fellow healthcare professionals in the country, what would be your word of encouragement for someone who's actually aspiring to be exactly like you? They want to become a clinical virologist. Any word of encouragement to them?
apply. Don't ever think, oh, I'm not qualified or I'm not gonna apply, and then let's take it from there. Don't don't say no to anything. If you are asked, if they say do this, if they say do that, if they say do you want to do this, just say yes. Take the opportunity and then you learn as you go along. You know, I think the best advice I ever had in the Rich program was from a colleague who said, um, just rather do it and then apologize later for it. That's if you're doubting yourself and you're like, oh, should I, shouldn't I do it? And then afterwards, if they were like, oh, you shouldn't have done it, you're like, oh my gosh, I'm so sorry. It won't happen again. It's better to do that and have the experience because that's how you learn, that's how you grow, than never doing it at all. And then you're sitting there and saying, oh, if only I'd done it, maybe it would have worked out. So that is my apply. Apply. You're underqualified. No one is ever fully qualified. No one is ever the right candidate. No one is ever apply and see what happens. When you get your opportunity, you just do it. Do it, do it, do it. Rather say sorry. Don't sit there and have regrets. Rather say, oh, I shouldn't have done that, than, oh, I didn't and I succeeded. So you, there is no you can't go wrong. It's like you apply, you can't go wrong. Everyone can do registrarship, everyone. You can't fail at registrarship, you can't, because even if you fail, you can change and do something else. There is no wrong path, there is no, and you might apply, find you don't like it, but you might find something you like in the lab still, or outside the lab, or you've just proven to yourself, this is not for me, that's for me. The point is take your chance, apply. Underqualified, overqualified, don't know, apply. Do it, do it, do it. That's all.
Yeah, no. Thank you so much for that. Dr. Moepeng, you're the best. You're the coolest pathologist I know. Pathologists are so cool, guys. They're so cool, I
All of
must
them.
say.
Yes.
You guys are the coolest bunch of doctors that I know. If you are so into, this vibe that I'm getting, then definitely you need to apply and become a pathologist because you guys are absolutely awesome. Thank you so much for all the information that you've shared. And where can people get hold of you? Like, do you have a social media handle somewhere
I,
where people can just say hello, for mentorship purposes? Because people will listen to your talk and they're going to be like, you know what, they want to reach out to you. Maybe they want to come and shadow for a day. Like, how do
yes.
people
Oh my
get hold
gosh.
of
Yeah.
you?
Okay. So I'm on Instagram. I think, what am I? Moepeng Maseko. If you type my name, you'll find me. I think I'm Moepeng Maseko on Instagram. On Facebook, Moepeng Maseko. On LinkedIn, Moepeng Maseko. Yeah. So Facebook, Instagram, LinkedIn, Moepeng Maseko.
Yeah, and yeah, definitely you are the voice of it's good to get doctors speaking about these issues. No, the public health um person in you, it's coming out. I can see it. Most I can see it. Then you must educate
That
us
is
more,
that is
You
the
must
future
educate us
plan.
more.
In 10
Yeah,
years, I would hope to be in like the policy space, making policies around
yes,
HIV, around guidelines, around all sorts of things. That's the plan. See?
absolutely. Clock it.
Uh-huh.
No, no. We'll be watching this space and we'll definitely be in touch. We'll definitely be in touch. We'll reach out.
Yes.
And yeah, it's such exciting stuff. All right,
Yeah.
Pepe, thank you so
Thank
much
you
for your time. And
for
thank you so much
having me.
for
Thank
everyone who joined. I hope I didn't lock anyone out. If you guys have any burning questions that I might not have asked, I hope I've asked everything. I saw a thank you. So my assumption is that everything that they wanted to know, they know. Now they know. All
you.
right.
Okay.
All right.
Thank
Maybe thank
you.
you so
Thanks
much.
so
All the
much.
best of luck. All the best of
Thank
luck.
you. Thanks,
All
you too.
right.
All
Okay,
right.
thanks. Bye. Good night.
Bye.